Thank you everyone for being here. Good afternoon. We are going to go ahead and get started. My name is María José Fernandez. I am the Coalition's Director for the Patients' Rights Action Fund, or also known as PRAF. For the benefit of some of our allies with disability, I am a late 20s woman of color, brown highlighted curly hair, fair skin, wearing pink glasses and a white blouse with a beige, I forgot the name, with a beige jacket with a white background. So today we have panelists for you who will provide their expertise on their professional and their personal perspectives. And as panelists, we have Anita Cameron. She is the director of Minority Outreach at Not Dead Yet since 2017. She has met with national and state policymakers and written persuasively about opposition to public policy of assisted suicide from the perspective of communities of color who experience disparities in access to healthcare. Anita also serves on the National Disability Leadership Alliance Racism Task Force and co-chairs the Intersectionality and Diversity Workgroup for ADAPT. As our second panelist, we have José Luis Barrera Novoa. He is a dreamer from Michoacán, Mexico, a strong advocate for immigrants' rights who believes in pushing for strong immigration reform in this country. Last month, José became the youngest elected vice president of LULAC in the organization's history and the first dreamer to take the role in the organization's 94 years. As our third panelist, we have Sherman Gillums Jr. He is a veteran and disability advocate, which has included work as an appellate representative at the Board of Veterans Appeals in Washington and serving as executive director for Paralyzed Veterans of America, chief strategy and advocacy officer for AMVETS, and chief strategy and impact officer for National Alliance on Mental Illness. He currently serves on the board of the Patients' Rights Action Fund / Institute for Patients' Rights, and we're very happy to have him on our board. And finally, you'll have me also as a panelist, but more in the host type of category, but I'll chime in where I can because as in addition to being Coalition's director, I myself am also Latina and I am a dreamer, so I do have a perspective to share on this topic as well. So I'm very excited to have you all here and to have you guys hear this discussion. For those who benefit, we also have ASL interpreters who will be interpreting everything that we're saying. They should be on the spotlight. Let us know if you cannot see them so that we can make sure that you can see that. A couple housekeeping rules. So this is going to be more of a conversation format. There is not going to be any presentations involved. So this will be more personal. Please don't hesitate to chime in for the panelists. Most questions will be for all, but if someone doesn't have something to say, then we'll carry on. But this is more of a conversation. I want it to be between us, like we're having a round table type of thing. And we will take questions from the audience. There's a Q&A function. You can submit your questions there. And by the end, we have questions that are prepped. So by the end of the questions that I have gone through that I have already prepared, if we have time, we will get through them. And if we don't have time for them, we will make sure to address those questions and send them out to all attendees via email or our website. This session is being recorded and we will share the link on all platforms afterwards. And for panelists, if you are not speaking at the moment, just please put your mic on mute so that there's no interruption for those who are speaking. If you benefit from closed captions, we have a closed captioning being provided. I believe you have to click a certain link to be able to view it. Otherwise, Zoom also has that option, but let us know if you are not able to access it and you need to. All right, so I'm going to go ahead and get started. So I want to start off the conversation with asking each of you if you have ever personally experienced healthcare discrimination. Anita, how about you first?
All the time. And I'm not trying to be flippant, but unfortunately, it happens. It is often blatant. And I guess I'll give an example. A couple of years ago, I was in the emergency room, and unfortunately, due to COVID, it was very, very busy. So patients were like out in the halls and everything right next to each other. And so I happened to be next to um, a person who, like me, was dealing with level 10 pain. Um, Without even asking her, the doctor, and we both had the same doctor that was taking care of us. Without her asking, she was offered and given Dilaudid, which is a very powerful narcotic medication. Um, I was given a pat on the shoulder, explained to that it was my MS. I have multiple sclerosis, and I was sent home. Um, as you probably imagine, the um, patient behind me happened to be white, and obviously I'm black. For the benefit of those who, um, who are blind or low vision like myself, I am a black woman with caramel colored skin. I have long locks, and I'm wearing a pink and black T-shirt that says "Not Dead Yet, the Resistance." So yeah, that's just one of the stories of discrimination. I'm often treated like a drug seeker when I go in for pain, even though I let them know that I'm allergic to all opioids and opiates. I'm still treated like a drug seeker. The doctors don't think outside of the box or anything when it comes to pain medication. I'm given a pat on the shoulder and sent home.
Wow. And sadly, that is what people of color tend to experience, and it's very frustrating. And thank you for sharing that. I know it's not a good memory to think about, so I really appreciate it. But I think that helps bring a little bit of perspective to the attendees that sometimes they might not think about how one might be discriminated. And so I really appreciate you sharing that. Jose or Sherman, would you, either of you would like to share a story of an experience of discrimination?
Yes. So the short answer is yes. Just growing up as undocumented, not having access to Medi-Cal or having any kind of health care provided by the state or private, there's been a lot of instances where having any association with a doctor has been a negative, or viewed to me as negative. And even as a young kid, that we would have to go to primary care health clinic where the main doctor, a Latino private practice, would still discriminate against us and dismiss our concerns due to the fact that we don't have health care. And so we would have to pay out of pocket. So that's gone on to even my adult life, where I was still not insured and having to go to this primary care physician has given us the understanding that, we come up with problems and we're going to get dismissed. And that's been problematic because, I got diagnosed with IBD, ulcerative colitis, and to the point where my problems and my symptoms were so bad that it was very much life-threatening. And going through the primary care physician, dismiss it as something else, or you'll see you for 5 minutes, and then we'll give you like a recommendation for something that was completely unrelated, right? And even going in through the healthcare system with good quality healthcare, it still takes months and years before you get a proper diagnosis and proper treatment that's going to benefit you. So yes, have experienced it, and it's largely due to the fact that I grew up as a low-income Latino in an immigrant family.
Thank you. I myself can attest to those sentiments and having similar experiences. Sherman, I'd love to hear what you would have to share about that.
Yeah, I'll preface my comments by saying that it can be hard to prove what motivated an act, right? And so when we're talking about discrimination, we're assuming the intent of the discriminator. And much of that assessment relies on how people come prepackaged. If you've seen discrimination, you know it when you see it. If you haven't seen a lot of it and you happen to be a person who's in one of these stigmatized groups, you know, you might see what is an innocent act, or maybe you might see something that is an innocent act and assume. So it's hard. It's hard because people don't want to go around looking for that stuff, but you kind of know it when you see it. And so they bring that history of experiences to this idea that somebody discriminated against them in healthcare. Because if you could see me, you would see that I'm medium brown skin, glasses, a dark sport coat, and a blue shirt, but you can't see the fact that I'm sitting in a wheelchair. So because I served in the military and suffered injury in the military, a lot of my care was in DOD and VA hospitals. And I have to say that I haven't seen discrimination in those spaces. And I think it's because of the even proportion of people of color who are also in those healthcare jobs. So I think that has a lot to do with my experience, although I'm a father of 4 daughters. And because my daughters didn't serve in the military, they do get care in places where most recently, my daughter who had my granddaughter, I saw what I thought was discrimination only because I'm aware of health systems and the way Black women get treated. I'm aware of the rate of cancer, misdiagnosis, the lack of treatment. So I'm very sensitive on behalf of my daughters. And recently she had a test that didn't come back favorable. And the first question I asked her was kind of an assumption. Okay, so what options did they give you? She said, well, they didn't really say anything else. Well, what are you talking about? I know that when I have a question about a test, they're going to give me alternatives to care and, things that may or may not work, but they're going to have that conversation with me. And when she said they didn't talk to her about something that was pretty serious and time sensitive, said that might be what they're talking about. When I hear these stats and all these statistics about how people are treated, I don't know, but I think that may be what I'm seeing. So the fact that we have to sort of pause and wonder, is the problem? Is it because of me, or is it because I'm Black, or is it because I'm brown, or is it because I'm, so yeah, just the fact you have to ask that question and you're presented with that dilemma makes it tough to navigate healthcare when you even have to think that way.
Yeah, that's very true. And in the answers that you guys all provided, it sort of answers a little bit of the second question that I had for you all about, what factors play into these racial disparities and in the lack of access to healthcare in general. I mean, JB talked about, the undocumented status, how that can then lead into not having the correct type of insurance. And then, the way that we look sadly might be something that then the doctor may automatically assume something, like Anita was saying, and you as well, Sherman. So it's really disappointing that sometimes just by the way that we look, or by something that a sort of paper or document that might be attached to our name, will then affect the way that we get treated, the type of services that we're offered. And I think it's really important to bring more attention to that, because I think unless you experience it, you don't know about it. So I'll just go into my next question and ask, what role do you think stigma and discrimination, which we kind of talked about, play into the decision-making process of patients with terminal illness for marginalized communities when they're considering their options? So we went a little bit into it, but I'd like to go, particularly since this is, in PRAF, we focus on assisted suicide. So we have someone, terminally ill, and they're from a marginalized community, and now they have what's like the setup for them, because what's going to make them then choose assisted suicide versus, their life-saving treatment? What's that stigma and discrimination that's going through the thoughts, like either through you personally or through experiences of family members or friends?
I guess I'll start it off, if that's okay. I think that the first problem in the Black community, and I'll say as a disclaimer, I don't speak for all Black people. We're not a monolith, and people have the different ways of experiencing being Black. So I'll just speak from my own sort of what has informed my view, as well as data. And the data show that suicide rates among Blacks are lower than other groups. And so when they're faced with that dilemma, there's a tension between the religiosity of the individual and their family, their options, right? A lot of people in those situations don't trust the system. And when even if they were approached with the option, to die on demand. Because of the history of the Black experience in America, we would wonder, why are you giving this to me? Because this is part of a, and I've had these conversations. I'm not, I don't come into this without wondering what other people think about these type of things. But those kind of questions, then it becomes a matter of, are you offering me this because I don't have any other options, right? So there's almost like a tension there in the Black community when faced with these decisions. It's really about how they're pre-wired before they get to that point. There's a stigma towards suicide in the Black community in many parts, but there's also a stigma towards mental health treatment. And a lot of it is based on mistrust. They mistrust systems. And I know a few older people that if they were presented with this option, it would be clearly in their mind an intention to kill them off, even if they've got, little time to live. I watched my grandmother and grandfather pass away. I don't think they were in a hurry at all, no matter how much pain they were in. So that's my sense of it. And others may have a different view of that, but that's my sense of it.
Yeah, and if I could follow Sherman, I think with the Latino community, speaking more specifically to immigrants, it's something similar. There's a distrust in the system. We come from countries that we frankly have a strong disbelief in our government leaders, and that translates into our government agencies and translates into our medical system. So when we come into the United States, we experience a system that, if we go to the doctor, it's because we're close to the edge, right? It's one of those concepts that you don't go into the ER or you don't go to your primary care physician until you have to go to the ER because it's gone that bad, and you're gonna have this idea of, I'm gonna toughen it out, I'm gonna get better, I'll just take an Advil or Tylenol, and that's gonna solve everything. So I think that's a major contributing factor to why people don't want to. And then the other part of it, it's economics. Can we really afford the medication? Can we try a home remedy that's going to solve the problem instead of having to take medicine and pay for whatever we have to pay for? So I think that is one of those big factors that we have to look into.
This Anita, I certainly agree, both with UJB and Sherman, when it comes to Black folks. I am someone who was born with disabilities, and so that whole distrust of the system is even, that I am Black, that I present as a woman, that I am a member of, that a number of marginalized communities that historically have not been well treated, um, you know, uh, by the medical profession. Um, and so even when I think those of us in communities of color are well off, we tend to have a healthy suspicion of the system. Add then to, being disabled, particularly being born with a disability because you went all your life experiencing discrimination at the hands of the medical profession, or experiencing a lack of consent, or a coercion or convincing to have things done to you and your body that you may not want. And for, certainly for us, um, even uh, the thought of, being offered, yeah, it's like, are you trying to kill me off? Are you trying to get rid of me? Is this, because I belong to so many marginalized groups and have been clearly discriminated against, for that, to even, if I were even offered that, I mean, that would be that would be red flags for me. I would imagine that the less marginalized you are, the more likely you're going to be to consider what someone is telling you. But as a member of multiple marginalized communities, that's the first thing we think of is, whoa, whoa, what's going on? I'm not trusting this. So yeah.
Can I throw out a quick data point? Highest rate of suicide in America, white men, middle-aged white men. Lowest rate of suicide, Black women. That'll
Wow.
tell you something.
But so then going to trying to tie this in more into assisted suicide. So, I mean, Sherman, you're saying like Black people are less likely to commit suicide, yet we have these like socioeconomic factors that are then sort of pushing them towards it. So then how does this, how do we deal with this? How can we ensure that, you know, that sort of mindset within the Black community doesn't get changed so that then they are then opting for assisted suicide?
I think Anita pointed out some of the danger. I don't think you're going to have more people pushing back against religion. I will say that a lot more younger people find themselves spiritually homeless. You know, they believe less in religion in some cases. But the scary part is not about whether you convince people that they should want to die, but whether you take away their capacity to decide. And when you get comfortable with taking populations that you can marginalize and de-autonomize, if that's a word, make it to where they don't make that decision. For example, in Canada, people with mental illness are now eligible for assisted suicide. So we get to a point where we don't even give people the choice to decide. We decide for them, or we put that in the hands of other people. And if you're Black and your loved ones are talked into this idea that you deserve to be free of pain and all these things they wouldn't have done, a lot of it is just by osmosis. The more it's normalized and it seems more acceptable, then the danger is that when people are in a position where they can't decide, I fear that more than a bunch of people deciding they want this. And to Anita's point, you know, having the capacity to choose, I think, is the affront that we need to watch for where the Black community is concerned.
And that's what I've been saying, this Anita, for years, that as assisted suicide gets normalized, you know, and racial disparities and disability discrimination will then combine to push us, you know, into a situation where we have no choice, because the choice is going to be removed from us, because a doctor or some other medical personnel may wind up putting us in a position, you know, to where we have no choice. What I'm seeing as like a really big danger is that groups like Compassionate Choices are making such inroads into the Black community, but they're doing it largely in professional class communities. They still haven't really reached into Black folks at a lower socioeconomic status, poorer folks. But I'm noticing that folks in the professional classes are I guess getting, you know, more convinced. When you're poor and, you know, you're poor and Black and disabled, it's a lot easier, you know, to take your choice away, because when you're living in poverty and when you're disabled, or if you're non-documented or whatnot, your lives are so regulated. Like every minute of your life is regulated, you know, to the point where if you're not careful, it can be extraordinarily easy for your choice to be taken away. And, you know, like I said, I think if you belong to, you know, a certain socioeconomic status and you've been convinced that your rights are being taken away, or this is an option that because I've seen compassionate choices like kind of twisted to say, racial disparities in healthcare are leading to people not being offered the choice of assisted suicide. What? And so, yes, we definitely have to be really cognizant and understand that choice and autonomy is a huge thing. When our consent and choice is gone, that's when they have us.
Completely agree. It highlights the inadequate, like the unequal access that we have in our healthcare system. To share just like a quick story, a personal story, I, as a dreamer, undocumented, have been knocked off from health insurance so many times. And so if I were to be put in the situation where I actually have been, where I actually suffered a panic attack, and due to not having health insurance, I didn't want to be taken into the hospital. I didn't want to take to the ER because I didn't want, and to have to pay that big bill. And so I just had to sort of like deal with it and have my family members and friends try to help and get me out of it. And for me, it was like the first time I was ever experiencing that. I had no idea like how to even work through that. And if I would have had that option, it would have probably been something, I know you don't necessarily have to go to the hospital for a panic attack, but as someone who has never experienced that, I was freaking out. I had no idea what was going on with me. And so it's something that I would just would have wanted, or maybe like urgent care, but that option wasn't available. And so those are the types of things that some people, they don't even have that option. And so then obviously when they get to a terminal illness, if I would have put in that situation, then the assisted suicide drugs would have probably seemed like the easier choice, the more feasible option for my family and I, just because it's going to be cheaper than actually, if I had some sort of other illness that maybe needed chemo or lots of, like a nurse with me or something like that. And so I think it's very critical, and to emphasize that fact that we need to have the options for it to be a true choice. Otherwise, then it's being forced upon us. And so then Sherman brought up a point earlier about where it's going in Canada. We can look to Canada to sort of see where this might actually come in the US. And, in Canada, they're requesting euthanasia due to poverty, inadequate housing, inability to access these services and proper care, these things that we're talking about that need to be given as an option. And so with time, how do you see this playing out in the US, and why should we be bigger advocates to not allow Canada to happen in the US?
Is that for me? Well, I've lived long enough to see the drinking age. Grew up in Buffalo, New York, right near Ontario and Toronto. It was 19 in Canada, and it was 21 here. Well, trends happen. We saw legalization of marijuana. These aren't bad things, but there is an osmosis effect. Canada's always been a little more loose with this. Doctors administer the drug. It doesn't take much time. The bar is very low. There's not a death on demand pill. The mental illness is a factor in whether somebody can decide to die. These are dangerous trends, and the more we see it working in other what we consider civil societies, and the more borders are blurred, right, by the contact we have, we may have people going over borders to do it, or finding it more acceptable. So I haven't seen it enough to worry that we're there yet, but I do know that veterans in Canada have the option to die in their system. That's not happening now, but I never want to see that happen. And it'd be a dangerous time for us to get to the point where we allow that. But, voters decided in several states to have physician-assisted suicide. All it takes is a year where a good campaign to make this legal takes root, and it could happen.
Thank
This,
you.
Anita, I watched it happen in Colorado. Colorado wound up, we we managed to defeat it all the time, when it came to the legislature. But once they put it on the ballot, yeah, I watched that tragedy happen, and I think that's the thing too, is that there are pockets, in our society that kind of believes or wants it, to be like Canada, or even other countries. There's a state senator here in New York, who's she's in Binghamton, and she's for assisted suicide because her constituents want that, and they want it for their children. And that's not even upon us yet, but they think that this is good for their children. They mentioned, this to this state legislator. And so um, there are pockets of people and organizations here in the United States, um, who do, feel like that, who feel as if we in the disability community, that we have a duty to die. If we're seniors, if we're sick, we have a duty to die. And I think that the organizations, I think because of the trending, the um funding and whatnot of the organizations to get, that word out, that view out, um members of legislative bodies, or whatnot, um putting forth legislation that may not necessarily see the light of day or whatnot. But like, for instance, in Colorado, there were 4 forms of assisted suicide, on the ballot. One of them was for out and out euthanasia. Well, that didn't make it, but it shows that people are, if we're not careful, we're going to get to that situation. And as long as the disparities in healthcare, as long as there's open bias between disabled folks, communities of color, marginalized communities, seniors, sick, you know, uh, that's going to be, and things are going to happen that communities aren't going to have any control over. I think about our indigenous communities here in the United States, that COVID wiped communities off the map. Whole indigenous nations gone, never to exist again because of COVID. But there's not much studies or whatnot on how indigenous communities feel about assisted suicide. All the indigenous folks, and I've spoken to quite a few, tend to be opposed to assisted suicide. It doesn't, it certainly isn't their in their cultural beliefs. And just like other communities of color, the disproportion and whatnot to medical. Because I think if you think communities of color have it bad, look at indigenous communities where stuff, they're colonized on their own land, and stuff doesn't even exist for you if you live on the res. And so we definitely have to be uh, uh, careful about a number of factors coming together to make us, if we're not careful, wind up like Canada.
Yeah, and let me chime in a little bit too. Here in California, I could see us winding up like Canada immediately. As a matter of fact, like there's probably like a real danger to have that happen. For various factors, right? We're looking at racial health inequities based on socioeconomic issues. And in California passed a bill, I think like last year or the year before, by Assemblymember Buffy Wicks that, helps address and look at these issues. But, that could be easily flipped where healthcare corporations see that, lower socioeconomic groups are not being profitable. Why? Probably because our Medi-Cal reimbursement rates are so bad that, they're not making money off low-income communities of color. So you could phrase that and say, well, since we're not making money, how do we make this more widely accessible, right? And one way to do it is to frame it as a choice. You frame it as on par with something like abortion issues, where it's being framed as an issue of freedom to choose what you do with your own body and autonomy. But that's not real autonomy if you're given a choice of life and death without really given the proper health care. So that's where I come from, and the idea that real choice and accessibility of healthcare needs to be expanded, not taken away from our people. And unfortunately, we keep seeing that there could literally be legislation, right around the corner where we see that happening in states that are more progressive leaning because they're being misguided and misled by wealthy companies that would probably benefit from this and save themselves a buck.
So we have someone in the audience who asked a question, and it sort of goes a little bit into what we've been talking about. So I sort of want to address it right now. They said that they have a good friend who is disabled, who was told directly by a university professor that she has a duty to die. How do you see this playing out in poor and minority communities?
Okay, well, I'll answer that. I had an experience where a tenant of mine who had lived with me and my family for years recently passed away because finally California expanded Medi-Cal into the undocumented communities. And so for the first time, he was able to get himself checked and treated. Well, turns out that he had a form of cancer and had, a term, he was to die in, set amount of time, but with proper care, he could extend his life for a couple of years. Well, he chose to not take the treatment for several factors. One, he didn't have family in the States. Two, he didn't have any money to pay for the treatment and it was going to be too expensive for him. And that really contributed to him just, letting himself go and passing away. So, when talking to him, it was really heartbreaking because, this is a man who had a lot of life, worked very hard, wanted to provide and send money back to his family in Mexico. And ultimately, he ended up dying alone because he felt that it was going to be too much of a burden for his family to be able to pay for the treatment. And it was going to be a lot. So he felt that it was his duty to just let go. And we could see that happening with many folks who feel like they're burdens to their families or they don't have the resources. So it'd just be easier for them to die rather than to get the proper treatment.
So I feel like in that scenario, it's more like they felt like they had no other choice, not so much that, oh, it's my right to die, which I think is what the question is trying to go into. But I think like what you said, JB, is true. When you have these different factors, it's obviously going to seem like, okay, choosing to die might be like the easier option. But I think that goes into the whole thing that we're talking about, we shouldn't have that be the scenario. But how do we address the fact that, we have proponents that are saying like it's people's choice, it's their right to be able to have this option to kill themselves, to die, and how can we see that playing out within our community? Sherman, I see you're unmuted, so I think you want to answer that.
Yeah, I want to frame sort of the mentality that would lead somebody to say something like that. For your attendees, I want you to look up ugly laws, right? Just Google ugly laws. These were laws that made it almost illegal to be in public if you were disabled or too poor, or if you were unhoused. They were rescinded in 1974. I was 2 years old when Chicago rescinded the ugly law, right? That we're not too far removed from that mentality. And just because the law was rescinded, the residual attitude, that professor, I wonder if that person was around when it's just like racism. If things become more tolerable when you make the extreme argument, this idea that we're going to kill people. Well, no, it's that Overton window mentality where let's make the extreme the argument, and then we'll shift it back to where it seems reasonable to tell people, well, you should want to die because you've got a disability. Why would you want to live like that? But those ugly laws, I'm always reminded that there was a time when this society thought it was okay to name a law an ugly law because somebody was disabled. And a lot of those people are still with us, right? So I would posit that that's that same sort of mentality that would let somebody have that come out of their mouth, somebody else with disability. And that's why it should be rejected.
Thank you.
And this, Anita, and sadly, that can lead to a coercion. If your doctor is of that ilk, that believes that you have a duty to die, and it could be your doctor that pressures you into assisted suicide, or to at least think about it. I mean, you have people with disabilities go through this already. I've had dear friends with disabilities or who acquired disabilities, and their doctors work on them and their family. You wouldn't want to live like this. You wouldn't want to put your family through this. You don't want to put your family through, financial or physical or emotional burden. I could see why, if we're not careful, you could, coerce someone into, you could try to convince somebody that, yeah, you have a duty to die, but you don't. And, people who espouse these laws, and I'm going to try to, they are, they're not looking at the big picture of how dangerous these laws are. Um, and so they put it forth that, I don't want to be in pain. I don't want to be a burden, to my family. I don't want to be this. And so, I'm gonna make that choice. But laws like these endanger so many groups of people. I mean, that literally it ends up endangering everyone. There just isn't any use or any place at all for laws like this. But unfortunately, um uh Sherman, the ugly laws, I just happened to research the ugly laws today. I heard a reference to it and was researching it today. So it definitely resounded, with me. But with the societal thinking, because despite the ugly laws being, repealed, I'm from Chicago. I was like 9 years old when the ugly laws were repealed, you know. Um, and unfortunately, we have to fight against that mentality. As long as you have that mentality that it's better dead to be than to be disabled, and that you have a duty then to take yourself out of the system, we're going to have these dangerous laws like this. There can never, ever, ever be any use for assisted suicide. And I think we have to continue to educate despite our opponents having bottomless pockets, and societal thinking on their side.
Thank you, Anita. So I sort of for my next question, I sort of know the answer, but I'd like for you all to sort of dive a little bit deeper, maybe share a little bit more than a simple yes. Because I want to point out this study. So there was a study of 714 physicians that found that 82.4% of them believed people with significant disabilities have worse quality of life than non-disabled people. And so the question is, do you think that the same attitude applies to BIPOC and economically disadvantaged people? And so I'm going to assume the answer for you all is yes, but like, can we dive a little bit deeper in that?
I'm going to mention a few studies that I found compelling, and I'm happy to share the links. There was research at the University of Virginia that found that more than half the white medical students and residents, these are future doctors, held false physiological beliefs about African Americans. 60% thought Black skin was thicker than other skin, and 12% thought their nerve endings were less sensitive than those of white people. Another study showed that white physicians implicitly prefer white patients because they view them as more intelligent, more likely to follow professional advice. The American Medical Association published a review of the relationship between pain and ethnicity in the Journal of Ethics, concluding that variations in treatment stem in part from racial misconceptions about heightened pain tolerance among African Americans and from the false notion that Blacks and Hispanics are more likely than whites to abuse drugs. That sound familiar here? That's the mentality we're talking about in that 712 physician study, where you ask the question, what informs their attitudes? And these aren't experienced doctors. These are new doctors coming into the system. These studies are only a few years old. And this is what they're finding empirically.
Thank you for sharing that. I think that's a very eye-opening for some, you know. I'm not surprised, but I'm sure some are surprised to hear that. So thank you for sharing that. JB or Anita, do you guys have things to add?
I'll say, Sherman, I'm glad you're coming up with all the facts and all the articles. You'll have to share those with me later. Of course, I'm gonna say yes. I think there's different attitudes to socially, economic, and BIPOC communities. So, and to elaborate on that, a lot of it could be the social economics, right? These people, brown, Black folks, are poor. You know, they don't have the resources. So I'm looking at it from like an economic standpoint, that they might view us as a drain on society, and why it's easier for them to get rid of us rather than to properly treat us, because we're going to cost the state, we're going to cost the hospitals, the systems more money than it actually that we'll be able to bring in, right? So we're just viewed as another number, right? And so for them, it's all dollar signs, and we're not profitable people. Then why would we want to treat them, and why would we want to work with them? And that's really what it comes down to, right? These systems will continuously oppress us and won't be able to be here in order to serve us. And that's where I believe that these attitudes come from.
Thank you for pointing that out, because I wanted to also, you know, talk about the cost savings that this is bringing in Canada. You know, it's been saving them about $140 million by having assisted suicide legal there. And so we see there's this deputy, he spoke about how, you know, it saves taxpayer money, and he asked how many people have been kept alive against their wishes in the past 5 years, and how their medication, you know, has using the assisted suicide drugs has basically saved the government from so much money. And so then I see this fear, at least within us, for our community, that then we're going to be then see like a dollar sign, like you're saying, JB, that they're going to be like, oh, well, they're not as valuable. They are going to cost us actually more money. So we should just allow them to take the suicide drugs and be done with it, you know? So I'm glad that you brought that up, and that it just shows how sometimes they're more, what is the word I'm looking for? They care more about like their profit and how much they're making, instead of the lives of actual people, human beings. So going into my next question, what steps do you think can be taken within the healthcare system to reduce healthcare disparities and ensure that all patients, regardless of their race or socioeconomic status, have equal access to quality healthcare and not have to consider assisted suicide? And where do you think the focus should be in healthcare for minorities? And I'd love for you all to answer that, and that'll probably be one of our final questions.
This is Anita. Unfortunately for me, I have no hope that racial disparities will end, because we are humans and we exist. And racism is hardwired into our system. It's in the very structure of our system and everything. And so we would, to me, in my opinion, we would have to have a total change of the human heart and soul, if you will, to totally eradicate that. There can be education, but, as Sherman was saying, look, I'm familiar with some of those studies that Sherman was talking about. Some of those studies are a couple of years old, literally, so, there's, so it's like, as long as we have human beings who exist and have biases and have power, it's not, we can educate the best we can. We can try to legislate, the best we can. But that's the reason why I say all the time that there's no place for assisted suicide, because as long as we have bias into our system, and it will always be, there is no place. I don't know, maybe other people have more hope. I don't have that hope.
Okay. I want to go back to your statement about the cost savings. I believe you said it was like about $140 million that Canada's saving a year from implementing this type of policy. And, to put that into perspective, $140 million is actually not a lot of money to think about when we're dealing with the whole country and their budgets. If we look at, the profit that healthcare corporations like HCA, which is the largest hospital system in the country, they're making profits in the billions, right? So 140 million compared to, a couple $1 billion is not a lot to save people's lives. But in order to change, I think we need to reprioritize our spending and what our values as a country are. We spend a lot on defense. We spend a lot of money on a bunch of different things, budgetary every single year with the US government. And oftentimes, some of the spending is wasteful and goes into endless programs that are not helping anyone. And to dive deeper into that, even within our own healthcare system, we're trying to cut corners, and by cutting corners, oftentimes we're getting sued. And those lawsuits are what's costing the consumer more money, because in order to offset the cost of the lawsuits, premium rates have to go up. So just reinventing the wheel is not going to be an easy task, and there's no one-way solution to make this happen. But those are a few things that I'm foreseeing that could help lead into a stronger system, so we could help address some of these issues.
So on one side is the angel that agrees with Anita, and on the other side is the angel that says, Sherman, you've got a 3-month-old and a 3-year-old granddaughter. You have to have hope. You have to believe it's going to get better. I'm the first generation post-civil rights, so I'm the latchkey Generation Xer that didn't do all the marches and see all that stuff. So I've seen the evolution happen, but I think you need to go upstream and get doctors at sooner in the pipeline, right? Have more doctors of color be interested, have more programs that steer more women and people of color, and even if they're not a person of color, people that understand empathy, and direct those people toward medical professions. But I think if we learn nothing else during COVID, it's the consequences of what happens when you neglect parts of society. their pain will be visited upon the broader society that didn't do anything about it. And people were dying, people who had wealth, who were affluent, they weren't immune to this disease. And because you still have to coexist with people, and you couldn't escape it just because you were on an ivory tower somewhere, that should have been a lesson. That when you let things go so bad, eventually that crack problem you had in inner cities becomes the meth problem you have in rural Ohio and Pennsylvania, and the systems that treated those people the way they did will have to receive those same people, and you're going to get the same result. So I think if we start looking at this, and it sounds corny, but we're on this big ball together, and start to invest in ways to save our society by the least among us who are the most stigmatized, so that we don't end up in a position where we're no better than they are in terms of our health, and where we end up with these systems. And Canada is a prime example of what can happen when things get so bad and people give up. This becomes the norm.
Thank you. I think you wrapped it up perfectly. And so I really appreciate everyone's comments. We are a minute until the top of the hour, so I am going to have to end it here. But we will get to the questions that didn't get answered. We will make sure to send out the links, the studies that Sherman provided during the webinar. And if you guys have any additional questions, just feel free to email us. You can email me at Maria Jose, MARIAJOSE @craft.org, and we can make sure to get those questions answered for you all. Thank you all again, and we will see you at our next webinar. Bye-bye.